My name is Nate Verhagen. I'm a second-year medical student at the Medical College of Wisconsin. And this summer, under the mentorship of Anai Kotari, I pursued the question of how perioperative COVID-19 increases surgical outcomes. And specifically, my project is titled Revisiting COVID-19 Surgical Timing Guidelines Using COVID-19 Severity in Cancer Patients. As an introduction, perioperative COVID-19 increases risk for adverse postoperative events. A lot of research early in the pandemic was able to show this. As a result, widely adopted guidelines delay surgery up to 8 weeks in patients with symptomatic COVID-19 to mitigate associated risk. And this is evident at MCW as well. Our preliminary research has shown that varying COVID-19 severity yields vastly different surgical outcomes. So to communicate actual results, we use hospitalized COVID-19 or ambulatory COVID-19 or non-hospitalized COVID-19 to describe COVID-19 severity. This will allow our research to be used across institutions. We had two objectives of this research. The first is to measure the risk of adverse postoperative events in patients with prior SARS-CoV-2 infection undergoing cancer-related surgical procedures. And the second, and maybe most importantly, is to determine optimal surgical timing delay in cancer patients based on severity of COVID-19. So ultimately, here are the methods that we use. So the database is called N3C, or National COVID Cohort Collaborative. It is the largest multi-site cohort of COVID-19 patients in the United States. And what we did is we isolated patients who had a cancer diagnosis and subsequently underwent surgery. These patients were then separated into those that did not have a history of COVID-19 and those that did have a history of COVID-19. These patients with COVID-19 were further subdivided into those that were hospitalized for their COVID-19 and those who had ambulatory COVID-19 or non-hospitalized. Then we also separate patients into surgical timing. So cancer surgeries after January 1st, 2020 were considered. COVID-19 diagnosis day was considered day 0. If you underwent surgery 0 to 4 weeks post COVID-19, you fell within that first group. If you had surgery 4 to 8 weeks, then you'd fall into that next group. And if you had surgery 8 weeks or greater following that COVID-19 diagnosis, you fell within that last group. So for results, in this patient characteristics table, what the main finding is that patients with a history of COVID-19 experience a longer time from cancer diagnosis to surgery, evidenced by the median of 70 days in those who did not have a history of COVID-19, and then 111 in patients who did have a history of COVID-19. Next, patients with a history of COVID-19 are at increased risk for adverse postoperative events, which is evidenced by mortality, hospital readmission, any complication, which is a composite, pneumonia, pulmonary embolism, and renal failure. Next, we wanted to compare how the two different COVID-19 severities yield different surgical outcomes. And what you can see is patients hospitalized for COVID-19 are significantly have increased rates of all adverse postoperative events that we assessed. So the ultimate implication of this is, how do we determine optimal surgical timing guidelines? And this figure does exactly that. We use a multivariable logistic regression analysis to compare the relationship between surgical timing and COVID-19 severity. And what you can see is patients with ambulatory COVID-19 are still at increased risk of postoperative adverse events when compared to patients without a history of COVID-19 at that 0 to 4 week time point. However, this risk goes away at 4 to 8 weeks, and then at 8 weeks or greater. Conversely, patients hospitalized for COVID-19 are at increased risk of adverse surgical outcomes at all assessed time points. And then this forest plot depicts the same trend visually. So in conclusion, time delay beyond 4 weeks from COVID-19 diagnosis to surgery in cancer patients with ambulatory COVID-19 appears to be unnecessary. And delaying surgery alone might not be adequate for mitigating surgical risk associated with previous hospitalization due to COVID-19. This is changing guidelines even at MCW currently. So for future directions, what we want to do is investigate the alternative perioperative programs that we can do to reduce the risk of adverse postoperative events in patients who were previously hospitalized for COVID-19. And then ultimately, we want to use machine learning to create a predictive model using preoperative factors, including COVID-19, to develop a personalized risk score for patients with prior COVID-19 to better inform their perioperative care. And ultimately, I just want to give you one last look at the poster and acknowledge Dr. Anai Kotari, who was just an outstanding mentor throughout this entire project. I really could not have done this without him. And then I'd like to thank the MCW's Department of Surgery for funding this project. And thank you for your attention.